So good morning, everybody. I'm Brian Ferguson, Chief Economist in Public Health England, and welcome to this session on investing in prevention to demonstrate value. We've got three great speakers here today. I'm going to introduce them all at once so that we just have continuity once we start, but I'm delighted to welcome John Appleby, who's a long-standing health economist colleague. John was previously Chief Economist at the King's Fund, who's now Chief Economist at the Nuffield Trust. Sally Burlington is a Head of Policy at the Local Government Association. Welcome back, Sally. You're so good last year, we've invited you back. And you know you're getting old when you're introducing one of your former MSc students. I supervised Will's MSc. I won't even try and remember the date that it happened, but despite that, Will's gone on to better things and become a Professor of Health Economics at the University of Bristol. So welcome to all three of you. So I'm going to say just a couple of minutes of very brief introduction and then pass over to John. John will be talking about the economic climate that we live in, which remains a very challenging one in both the NHS and local government. If I just say the words Spending Review 2019 and NHS Longer Term Plan, I think those are two areas where we're trying to do a lot to influence, as you've already heard from Duncan this morning. Both these areas are areas that will be upping our game on investing in prevention over the next few months. Demonstrating the value of prevention is equally important, and Will be talking about that. And the question about what we mean by value is not just an academic question. It has profound implications for things like the cost effectiveness threshold that NICE and others use, profound implications for how we make the economic case to Treasury and others about investing in prevention. So Will be talking about that, and in between that, Sally will be giving us some insight into some of the challenges of making the case for investing in prevention locally. As Sally will say, there are compelling arguments for prevention, but we need to look at wider economic value, not just the question of cost savings or cash release. So Sally will be talking about the barriers, particularly in a politically driven system, both locally and, of course, nationally. So without me saying any more, let me pass over to John, who's going to give us the macroeconomic picture first.
All right, thanks, Brian. And I think we have a very specific 14 minutes. Not quite sure why it's 14. We'll round it up to 15, being an economist. I think my job is to present the relatively dismal sort of macro financial picture and context for this session, as Brian said. So I want to say something about money sort of globally and in relation to public health, but also something about population's health, and referring back to Derek Wanless and his scenarios for funding and for population health and public spending. So I'm trying to set the context for some of the issues around value for money and return on investment and so on. So I can't, oh yes, it's up there. So just something on funding. And here's a very big picture, historically as well as sort of macro. This shows the real changes in English NHS spending from 1951 to 2023-4. And I've added in the planned increases. Brian referred to spending review next year. The official line is that the NHS will get an extra 3.4% real terms increase each year from 2019, 2020 onwards. In fact, that just refers to NHS England, which is the majority of the NHS budget. So in terms of the whole of the NHS, all spending, it works out roughly at about a 3% real increase each year for the next 5 years. And just to put that in context, and you can see from the chart really, long term, up to 2009, from 1951, the NHS, although it's gone up and down, as you can see, has had a real terms increase of about 4% each year over and above inflation. 2010 to current year, the increase has been about 1.5%. So the next few years, it's about half the rate that we've seen from the turn of the century up to 2009, which was around 6% real increase. So it's more money, and everybody would welcome that, but it's not the sorts of extra real money that the NHS was used to over those decade from 2000. So that's the sort of big context. And just referring back to Derek Wanless, I've updated some of these numbers. They're in 2002-3 prices. These were the scenarios, I'm sure you all remember these, the fully engaged, solid progress, slow uptake. This is spend for the UK, and these are the sort of projections. They're not predictions, they're projections that Derek and his team made based on a whole set of assumptions about, importantly, the productivity in the NHS, the state of the public's health, the state of public health spending, and so on. And in fact, it's those three things, public health spending, and productivity, which really drive the differences between those scenarios. So how do we compare? What was the actual turnout? Well, that's what it looks like into the future. So we're about 38 billion lower than the fully engaged scenario by 2022-23. And you can look at that in terms of percentage of GDP. So Wanless was projecting something like 9.5% of GDP on the NHS by 2022-23 for fully engaged. It looks like it's going to be something like that, just over 2% less than GDP. So that's the situation sort of globally. So what about public health? As I say, the thing which really drove the differences between Wanless's three scenarios were productivity, a key thing. More productivity, less spend needed. Less productivity, more spend needed. But also public health spend and also the state of the public's health. So what's been going on with public health spend? I mean, a clear caveat, as you all know, it's actually very hard to pin down exactly public health spend related to public health activity. This is the sort of official budget, if you like, from 2013-14. Clearly, there's other spending that goes on within healthcare and within local authorities, which you could call public health. But this is the official budget. These are figures, I've updated them, but my old colleague Dave Buck at the King's Fund did this sort of analysis on the budgets that were published, and he's taken out the 0 to 5 children's services just so we can get some comparison. One of my sort of, as an economist, trying to examine government budgets, the fact that budgets move around, other things are added to them and so on, makes it quite difficult to track over time, but this is the best guess we've got. And as you can see, it's about a 24% real cut, around £690 million in today's prices compared to 2014-15. And over the last few years, we've been able to break down that budget, and those cuts have not been evenly distributed, as you probably know. We've got cuts in children's services, substance misuse, sexual health services, and so on. By the way, all these slides will be available if people need to get hold of these numbers and so on. Another way of cutting it is to broadly group those services by age, if you like, children, adults. Sorry, that word mixed, it's meant to be both, I think. That's a bit of a typo on my part. And this is just over the last couple of years, 2016-17 to 2018. And these are the sort of percentage cuts, and you can also see the figures in millions of pounds at the bottom there as well. So, slow growth globally, real cuts in public health as far as we can tell, as best as we can tell from the published data. Just want to turn to something on outcomes now and the public's health, because I said, and also productivity. I said these are important in terms of driving the Wanless scenarios and where we're at the moment. And it's clear that, I mean, using Wanless's scenario terminology, that funding, in a sense, is way beyond fully engaged. And of course, the fully engaged scenario implies a whole set of assumptions about how productive the NHS is, how well it uses its money, population health, as I say, and the public health spending. So how are we doing on some of those? And I've just been a bit selective where I can in terms of getting data. And actually, some of this echoes the PHE publication today, of course. Well, starting with some good news, smoking. Wanless's scenarios use these assumptions. Slow uptake, you can read it yourself, solid progress, fully engaged. In fact, the actual smoking rate, at least in 2016, around 15%, again, not distributed evenly across population groups and geographically, but in aggregate, good progress there. Life expectancy at birth by 2022. The reasons I picked out these were these because Wanless actually specifically put figures to some of these public health measures and health determinants. Solid progress, would you say? Just to bear in mind, as I'm sure you're aware, that life expectancy figures are projections. They're based on a number of factors, mainly mortality rates and so on, and assumptions about that. And there's some reasons to believe that they're perhaps overestimating. As you'll see, another couple of slides I've got on mortality. Avoidable mortality, you can see the bar there and the line chart there. Last few years, there seems to be a bend in the curve going on here. I'm sure you're all aware of these figures. The extent to which this will eventually feed through to the life expectancy calculations will happen over the next few years if these trends continue. Just some more on mortality. This is a recent ONS publication looking at the reductions in mortality in two time periods, 2006 to 2011 and 2011 to 2016, which is the blue bars. And you can see the reductions seem to be stalling both for men and for women. Oops. And just some international comparisons. Again, this is from ONS recently, the last month or so. And this is part of their examination of these recent trends where mortality in absolute terms is going up and mortality rates seem to be stalling. And it looks like, and I've just selected this, not quite at random, but this is the annual average increase in weeks in period life expectancy at age 65 for women and selected countries. And you can see the preceding 6 years, the blue dots, and the most recent 6 years, the red dots. And the UK has had the largest slowdown in life expectancy for that population group. Obesity, well, again, Wanless set some figures to feed into his models and scenarios. Slow uptake, something around a fifth or more of people classified as obese. Solid progress, down below 8%, similarly to fully engaged. But you can see the figures. We all know these figures, I think. Around 27, 28% for men and for women. And just lastly on these actual figures from Wanless, productivity, as I say, this is also, as an economist, this is key to the sort of funding money the NHS will need in the future. Again, Wanless made some assumptions about productivity, slow uptake, something like 1.5% productivity increase a year, solid progress getting up to 3%, fully engaged, again up to 3% productivity increases a year. In fact, the figures we have for the UK, 22 to 2016, suggest something like a 1.5 or 1.1%, increase in productivity each year. Last few years, the NHS has been producing higher figures than that. I suspect mainly because of the slowdown in funding, and like some supertanker, the NHS is still producing activity. But I think the latest figure for 2016 shows a slowdown in productivity. So that's the broad sort of macro picture. And just finally on this slide, on this conclusion, so we've got two crucial elements of Wanless's assumptions about future spend, productivity in the public's health and health determinants. They're clearly around the sort of slow uptake scenario for Wanless. But clearly public spending on the NHS and especially on public health implies somehow a better than fully engaged scenario. As I say, the planned extra spending over the next few years, in my view, will not significantly reduce financial pressures. I mean, one of the things to bear in mind, I think today NHS Improvement published the first quarter figures for the provider sector. For the first time, they published what's called the underlying deficit in the provider sector system. So The top line is something like 800 million overspent. The bottom line, if you like, the underlying deficit is something like 4.3 billion pounds. The difference between those two figures are the sort of one-off savings that accountants can put into their accounts to reduce that deficit. But if you talk to directors of finance, of course, it's that underlying pressures which really, that's the thing they really worry about. So the system is starting in a big financial hole, and we know in terms of its performance, it's also starting from less than year zero, if you like. So there are going to be a lot of calls on that extra 3 and a bit % money. But I think this macro context, as I say here, really does emphasise the importance of prioritising investment of every NHS and every public health pound to maximise health returns. There isn't going to be any more money apart from that money advertised by the Prime Minister this summer. Getting the most out of that money is an absolute imperative for the system as a whole. Thanks very much.
Good morning, everybody. I'm Sally Burlington. I'll just wait for the slides to upload. I would like to really agree with the point that John ended on in terms of needing to get the absolute maximum value out of every public pound spent, and I'll talk a bit about that as I get into the slides. I really want to talk about the value that we get from prevention and how that feels locally, and offer some reflections about how we might address some of the questions that raises in a local situation. Is this working? Yeah, great. So I'll spend a little bit of time on context. I'll talk a bit about politics in a local context and what that means for value and how politics might see value. And I'll talk about return on investment and some of the ways in which value can be measured and what that means for local choices. The bleak bit that you'd expect me to point out is what's happened to local government funding. This isn't just public health funding. John talked about that specifically. But local government funding between 2010 and 2020 will have reduced by about 60% in real terms. Just think about that figure. And that's core government funding for local government. And it's a saving to the taxpayer of £16 billion a year. So this is a huge order of magnitude. And in addition to that, some of the ring-fenced grants, we've talked about public health, early intervention funding, and some of those other specific funds that are for preventative services have been cut as well. And this matters because when you think about the role of local government broadly, and you think about all of the wider determinants of health and well-being, you're inevitably thinking about housing, leisure, not only public health but social care, children's services, the role of education, licensing, planning, the things that make up our places and the public services which people rely on, the transport that people use to make their social connections and create the well-being that they rely on for their mental health and wider well-being and physical health. So this infrastructure that's provided by local governments in every area is really crucial as one of the upstream factors contributing to prevention, both generally and specifically. Local government has responsibility for about 900 services in all and over 3,000 statutory duties. I'll come back to statutory duties a bit later on. So we talk about prevention a lot. We all talk about prevention a lot. It's obvious that we should do it. People call it a no-brainer. We've spent a long time in the LGA and more widely making the case for prevention, and we think it's really obvious in principle, and it's obvious when you look at evaluation evidence. There have been lots and lots of studies like the ones we quote here, which look mainly at costs averted to the public purse. So they will count costs that can be averted in one's own service. So there's a case for an investment, a business case that can be made locally within the service that you're providing, not just public health, but more widely. But very often we also count the costs averted to the wider public sector. We sometimes, in social policy, also count the costs averted in terms of the impact of crime. So it can include personal costs, private costs, and so on. And it can include the costs averted in terms of the benefits bill and welfare spending. There's a very well-rehearsed economic literature on all this, and no doubt we'll talk about that some more later. It also, of course, can estimate the benefit of the impact on people's own outcomes and their health and well-being. And when we do a full cost-benefit analysis, we take account of the quality-adjusted life years, and I know we'll talk about that later, on people's individual well-being. So economic value can be defined incredibly broadly. It can also estimate the impact on the economy more widely through productivity and our ability to work and so on. So when you count all that up, it can be huge. And studies vary in what they include. So I'm going to talk a bit about why that's important. The other thing to note, though, is that when we estimate economic value, one of the measures we can use is willingness to pay. And we do that because if you're willing to pay for something, it's assumed that you value it. So if people are prepared to pay something, we sometimes estimate the value of what the thing is, whether it's a product or something more widely, by what people are prepared to pay for it. But what this means is that if people care about something, it has a value. And so when Duncan was talking earlier about needing the consent of the people, there's something that we need to reflect on in terms of the importance of what local people care about for how we consider the value of the interventions that we put in place in public health and in wider social policy and throughout the work that local government does. We have lots of examples of infographics which use these economic analyses to emphasise the value of prevention. And we've done a lot of these over the years. You'll be familiar with many of them. They're really important for helping to explain to people the real value in any number of ways of different forms of intervention. And in addition to these, there are lots of examples of where you can estimate real cash savings to the public sector from particular interventions. In 2015, the LGA published a document calling for a prevention transformation fund, which argued that if you had a really carefully tailored fund which was locally implemented but focused on those interventions which not only have wider economic benefits but can also deliver cashable savings to local public services within, say, a 5-year period, thinking about political cycles and the terms of a parliament and so on, then actually you can make these a kind of real investment in prevention both pay for itself and have that wider economic value. Of course, we haven't got a prevention transformation fund. It hasn't been delivered. One of my reflections is why is it so difficult in practice to make the shift from services that fund the heavy end, the costs of failure, of illness and so on, towards prevention in a really substantial way? One answer, of course, is that at the moment we're in a world where we're having to make cuts. We're not looking at investment cases saying how shall we spend our extra millions. Every year, councils and others are having to make really difficult choices about where we have to make the cuts, and they're having to do that in a really well-informed, really careful way. But the choice you're making isn't just, is this good value for money, shall we invest in it? The choice one has to make is this better value for money than everything else we currently spend on? And can we think really creatively about driving out efficiencies, thinking differently, innovating, so that we're getting even more value out of every public pound than we had before in order to justify doing something more and more preventative? It's not just that, though. So I talked about over 3,000 statutory duties for local government. Our statutory duties tend to be the things that really matter. They tend to be acute services, those very, very difficult things, child protection, things that pick up the pieces when things have gone wrong in people's lives. So in a world where there's less money, you have to prioritise your statutory interventions. That makes it harder to prioritise things which are discretionary, and that tends to be more of the preventative services. Of course, we can think creatively about that, and we have to, but it's not easy. Also, when we make an invest to save case, we need to be really clear that in making a business case in any system, there are lots of different tests that you need to apply. So if you're talking about savings, I talked about earlier, there might be savings to your service, but it might be to the NHS, it might be to other services. If you can't find a way to extract those cashable savings in practice, then your business case feels a bit weaker, doesn't it? It may still be worth doing, but it's a different kind of dialogue. In addition to that, savings accrue over a time period. We could talk about the discount rate that economists apply to take account of the fact that savings in 15 or 20 years are worth less than savings right now. But that is a really valid consideration, particularly if you've got a reducing profile of spending over time. And risk and uncertainty is a huge factor. When there are deals being done about partnerships between health and social care and other partnerships locally, we're now much more actively talking about risk sharing. What happens if things don't work? What happens if the cashable savings aren't delivered? And we need to be realistic that when we look at our infographics that say, you could deliver this level of benefit, that depends on how you do it, whether you do it well, whether you can find the workforce, any number of practical considerations that can really affect the impact of what you do. And as a former Whitehall official, it really is difficult for people sitting in government to understand how very difficult it is to deliver very effective services locally, to make them stick, to keep them going, to keep staff motivated and to deliver the outcomes, the savings and the improvements that we might put in our business case up front. So it's not enough, in effect, to say there will be savings to us, to the NHS, to others. We're having to get much more granular and detailed than that. Furthermore, when we look across the vast range of evidence, there's a burgeoning amount of evidence, isn't there, which is great. But the most brilliant expert in the world won't be able to give you the answer of what you should therefore do in your place. There isn't a technical single answer when you look across all the evidence. It can tell you the areas that you should prioritise and what's most important in your place, what are the most costly problems that you're facing in economic and human terms. But it can't tell you easily how you should address that and what's the most cost-effective place to put your extra pound if you can find it. So we do need judgment. And fortunately, we have health and wellbeing boards and local politicians whose job it is to help inform some of these choices in public health, but across local services. But what they need isn't just a huge amount of evidence. We need proper justifications that make sense to the public. We need to be able, as Duncan said, to have the consent of the people, and that means being able to tell a story that makes sense in a complex world to people who have part of the picture and care deeply about some things. And that political job is really difficult, and it requires very, very expert advice from directors of public health, from other experts locally, and wise judgment, careful judgment about how you take account of different evidence in these complex systems and think very creatively, innovatively about how in practice you can really make a difference to people's lives. We also need, as I said, to talk about what happens if you don't spend money on things and weigh up the opportunity cost of not being able to invest in this service or that service as a consequence of whatever you're doing in a preventative agenda. And that's difficult and sometimes painful. And the process of doing joint strategic needs assessments, which is the most obvious way in which we do this every year, is really complex, and my hats go off to all the people that do that every year. It is really complex and difficult, and we're getting better at it over time, but let's not underestimate how difficult that is. And how we think about the whole system and the asset-based approach that people have already talked about today, and whole people that we're working with, how we work with people with long-term conditions, how we think about our systems in ways that properly support people in the ways they need to be supported for maximum impact. All of that is really difficult. So what would help? We need to think systems, not just interventions, and a bit of a plea to those who are evaluators in the room. We've got really good at doing evaluations robustly, haven't we? Randomised control trials, gold standard, brilliant, really helpful. But in a world where we're trying to make a systemic change and a series of changes to the way we work across local systems to do better for our populations, how can we evaluate that in practice in a way that's rigorous enough not necessarily gold standard, to satisfy the case for investment that we have to make up front, but also doesn't cost a fortune, doesn't take 20 years, and won't be subject of loads of academic debate later. We need to get better at this as business as usual. Targeting is crucial. So the Treasury talk about dead weight. This is really important when you haven't got enough money. Dead weight is the economic term for the cost of paying people to do stuff they would have done anyway, or giving money to people who don't change behaviour as a result. So targeting interventions on those populations for whom it will make the biggest difference and where you wouldn't see that difference otherwise is really important. It's an economic concept, but actually it gets much more acute in a world where we haven't got enough money. And as we think about wider upstream interventions, that's even harder, isn't it? Because if the risk factors that you want to target aren't obvious and displaying, and you're trying to target them really upstream and talk about universal services, then it's even harder to make your business case in a world of constraint. We need to be honest about what a saving is. So a cost-benefit analysis might include a very wide range of economic benefits. They are all worthwhile, they are all valuable. We shouldn't deny that, but they're not the same as cost savings. And we do the public a disservice if we pretend that they are cost savings. And it's actually not always very easy when you're reading an analytical document to know whether it's a cost saving or whether it's a wider economic benefit. But all analysts and all of us have a responsibility really to try and think about that. And unless we do, we will reinforce optimism bias, and we will tend to overpromise what we can deliver through prevention. And I think we have done that collectively as a society over recent decades. And that makes it even harder to make the case to the Treasury in a spending review that if you invest in prevention now, it will deliver savings later on. Because it's not that simple, is it? But we need to have the realistic conversation. Uncertainty is the other thing I just wanted to mention. There's something really important about trying to work out whether your plan is delivering what you thought it would deliver as you go along, and that's a multidisciplinary job. It's not just an economic job, it's not just a public health job. It's a proper analytical, multidisciplinary job, and one that needs to engage with politicians and decision makers, and that's part of getting this right. I will also mention David Buck. He's going to get a couple of mentions, and you'll be glad to know I'm about to finish. We need to be clear that things are worth doing even if they don't deliver cost savings, but we shouldn't conflate the two. And my final slide, I like this slide, but actually it kind of oversimplifies the choices in a place. Every place has its own set of these choices that is different according to your local population, your local need, and so on. And there are lots and lots of different possible paths to the right, which are technically correct. But actually you need to work out which of those choices to make locally in careful consideration of your own judgments locally, your own engagement with the public, your own plans and priorities, and reviewing where you're at on that path as you go along, and then adapting it if necessary is also crucial. I'll stop there.
Thanks and good morning. So my name's Will Hollingworth. I'm a health economist at the University of Bristol. And so I guess my perspective on what is value in public health is less of a big picture top-down one, and I'm going to talk a little bit more from the bottom up and how we might measure it and produce robust evidence of the value of public health interventions. My slide set is so huge, it's taking a while to open up. There we go. Okay. So my starting point then is how can we determine, or even whether we should be trying to compare the value of let's say, health promotion, prevention of ill health and cure. If Google doesn't let me down, I think this was Benjamin Franklin who said the statement. And so I'm interested in thinking about how we measure that, how we compare between the two. For younger members of the audience and for older members like me who are just no good at baking, I've put the conversion down in the bottom right-hand corner. So do we really expect public health interventions to be 16 times as good as the sorts of drugs that NICE evaluates? Or do we even expect to be able to make that comparison? And if so, how do we do it? It's not going to be in pounds and ounces, I hope. I'll just talk a little bit about how we might try to define value in public health interventions, how we then would go about measuring it, and finally, how we then try to demonstrate it to people who we want to take notice of it and act upon it. So I'm going to cheat a little bit by not defining it by what I think it is, but defining it by what I think it isn't, or not purely. So my starting point is that I don't think it's purely a measure of health benefit, the value of public health, and not as is typically typified by the quality adjusted life year. That health economists like myself have grown up with it. It was there in, Brian was too polite to mention it, but it was 1992 when I did my master's, and the methodology hasn't changed that much since then. So quality adjusted life year, as a measure of value, as most of you will know in the audience, it tries to combine both mortality and morbidity into one summary score, so that someone who lives a year of life in excellent, perfect health has one QALY. Someone who lives a year of life in intermediate health might have 0.5 QALYs, and we could then equate that with someone who lives for 6 months in perfect quality of life. So it makes that translation between health-related quality of life and mortality. And NICE has used it a lot, but I work across a range of trials at Bristol, some public health interventions, some not. And it's particularly noticeable that for the public health interventions, particularly the health promotion ones, the QALY as measured by the EQ5D, which is the questionnaire in the bottom right here, doesn't really feel like a good fit for what the interventions are trying to do. It works for some, I would say. So HepCat is a detection and treatment of HCV in primary care. And for that, it seems like a reasonable outcome measure. We are trying to improve the health and survival of those patients. But once I get into more health promotion trials, I guess the shortcomings of the QALY as a measure of value become apparent. So just to talk through it in case you can't see it, the EQ5D measures mobility, self-care, usual activities, pain, and anxiety, depression. So a very simple questionnaire and quite narrow, I guess, in its health focus. So WISE is a mental health intervention to improve the mental health of secondary school teachers. What are we trying to do there? Well, yes, there is a health target, improving the teachers' mental health, but actually there's a whole broader issue of things which the QALY is never going to pick up. We're trying to encourage students' and teachers' engagement in lessons, students' enjoyment of school, perhaps their educational attainment even. And we're missing lots of that if we just have a narrow definition and measure of value. Frank is a peer-led drug prevention initiative in secondary schools. Again, if we just focus on the health of people, we arguably will miss a lot of the well-being and life opportunity advantages of preventing a teenager beginning to use drugs. So thinking of Sally's concentric circles, I think often the QALY works for interventions targeted at individuals. It gets less and less useful in many cases when you go outside of the concentric circles and think about community interventions to improve the environment and so on. Now, I'd argue that in the last 10 years, actually, broader measures of well-being have been developed, and they're by no means the finished product yet, but should become part of the conversation in defining what is value in public health. So the example I've given here is on the bottom right is a measure called IceCap, which focuses more on well-being, more broadly defined than narrow health. In case you can't read it, it talks about, it tries to measure feeling settled and secure, feeling love and support, being independent, having achievements and progress, and enjoyment and pleasure. Now, that's not a perfect fit either for all the studies that I do in public health, but for some studies it feels like a much better measure of what they're trying to achieve. So that's a sort of, my gut feeling on it, but there is also some evidence that it might perform better as a measure. So for instance, there's a recent study in a small group of individuals receiving opiate substitution treatment. And the EQ5D, which is the basis of the QALY, on that measure, more than 1/4 of them rated their health as perfect. It couldn't be improved, which is potentially a problem if you're trying to demonstrate change over time and improvements over time, whereas the proportion at the ceiling level was about 1% for the ICE-CAP. So I think there's a lot of work to be done with these measures and finding out where they work better than the traditional measures of health, but there are possibilities here. But there are also challenges to moving away from what has been the paradigm. NICE has been going since 1999. In many ways, the sustainability, the survival of NICE is completely tied up with the success of the QALY as being seen as a reasonable measure of value of most treatments. But the question is now, NICE's remit has expanded to public health. Is the QALY still fit for purpose for that? So do we need to have a measure that we can compare across health promotion and, let's say, chemotherapy for cancer? I'm not convinced, actually, myself, that we do need to do that. So I think some of the challenges are more on paper than in reality. But I would say that there are still challenges and more empirical evidence is needed on the value of these well-being measures and how they perform and in trials. There's also unresolved issues. Should we expect well-being measures in elderly patients to be the same as well-being measures in adults? Do people towards the end of their lives value different things? And how much do we want to take that into account in our decision-making? Second thing I want to say that value isn't is it's not purely maximisation. And in terms of the economic evaluation process at NICE, that essentially doesn't try to weight the benefits of public health interventions according to whom gets them, whether they come from a deprived community or an affluent community. And I think that runs a risk. And I barely need to show this because it was basically demonstrated nicely in the plenary this morning, but basically, whilst life expectancy and disability, adjusted life expectancy have increased, that's the shift upwards to the blue and the grey dots, between 1999, the start of NICE, and 2013, the gradient of these lines, which measures the inequalities, hasn't changed over that time period. So NICE has focused to an extent on certainly the economic evaluation has on maximising QALYs. And at the same time, we've got this persistent inequality. Now, as an economist, you can either say, okay, that's an intractable problem, or it's somebody else's problem, or you can try and think about how you would incorporate that in your measure of value. And there's a long, long way to go on this. But again, there are people doing work in this area which might eventually be part of the routine of how we define value in public health. So NICE does consider equity impacts, but it's part of the deliberative process. And that's good. I wouldn't argue that it shouldn't be there. But actually, I think we could go further, perhaps, and think about how we incorporate equity weights in our estimates of value and benefit. And ideas such as sufficient capabilities, I've just given a couple of references. I can't give the full spiel here. So do we want to value getting people up to a certain minimum level of well-being more than moving someone who's already very close to the top further upwards? So these ideas are being discussed. They're not yet, I would say, ready for routine use. Okay, second point I want to just touch on is So, okay, if we can try to define value better for public health interventions, how do we measure or provide robust evidence better? I come from a world of RCTs, which I realize is a very ivory tower and tip of the iceberg part of the world. And I just looked actually at the funding of study designs by the NIHR Public Health Research Panel. So this is 2014 in the blue, 2017 in the orange. And the predominant methodology study design is still the RCT. You can see actually there's a small increase in recent times in the natural experiments. And I just wonder whether we're missing something here. Obviously, RCT has high validity, high quality evidence, but there are plenty of public health interventions where it's difficult or impossible to do it. And so I think the better availability of linked routine data could really help us here, and we should be making more use of natural experiments. The data, of course, that's missing is the data on well-being. I mean, routine, I can get access to hospital admissions or maybe GP visits. I don't really have a good way of getting routine data on the well-being of people in North Bristol versus South Bristol, for instance. That's more difficult to get hold of. Okay, I'm going to skip on in the interest of time. I will say just a list of there are another 4 or 5 challenges to measuring the value of public health interventions. And I'll just leave them there so that you can, if you want, explore them further. It's not straightforward, but then again, I wouldn't say it's much more difficult than the trials I do in surgery. I can recruit, well, not me personally, but we can recruit 200 school children in a clustered school quite easily. It's quite hard to recruit 200 patients about to undergo surgery. Final points then. Okay, so how, if we can define it better and measure it better, how do we go about demonstrating it better? And this has already been touched upon. I think return on investment is a great advocacy tool. It demonstrates to people who don't want to go into the intricacies of QALYs, et cetera, the potential value of public health interventions. And there's a great story to be told for many of those. I've just given a couple of examples from the Canadian Public Health Association and the American Public Health Association. And this is a systematic review of return on investment estimates in the literature, just focusing on the left-hand one. So this gets as close as we can to answering Benjamin Franklin's statement. So NICE for drugs, technologies, treatments probably it requires a return on investment of about 0 or 1, depending on how valuable you think a QALY is. The median from the literature of public health interventions, well, you can squint as well as I can, perhaps, is about 10 or 12, and there's a huge range around that. So it might not be 16 times, but there is some evidence that many public health interventions are producing much more value than treatments often approved by NICE. But as a researcher, a skeptical researcher, there are very inconsistent methods for calculating return on investment. I wouldn't say it's a good method at the moment of priority setting within local authorities, because it is very difficult to value some of the less tangible or uncertain benefits of many public health interventions. I'm going to just conclude there with a few thoughts, which you can either come back on in the discussion section, or you can completely ignore if you don't think they're relevant. But I thought they were interesting. Will the QALY still be used to value public health interventions in 10 years? Should it be? Does it matter if the definition of value differs between health promotion and NHS treatments? Is equity already adequately included in the process that we go through to define value and decide on what to do and what not to do? And finally, are we missing opportunities for using routine data better in natural experiments? If so, how can we change that? And the return on investment tool, is it purely for advocacy, as I tend to think, or is it ready for use for setting priorities within local government? Thank you.
Okay, thank you very much, John, Sally and Will. We've got time probably for a couple of questions. So could you please say who you are and where you're from? One over here, please.
Hi, Liam Nicholson from the Clinical Network in Yorkshire and the Humber. My question's for sort of anyone who feels able to answer it, really. So going back to one of the slides about return on investment for something, for example, alcohol intervention. The figure listed in the slide was £12 saved for £1 spent. I'm curious about what level of investment that holds true until. So, for example, if the government invested £500,000 into it, it feels quite reasonable that they could get £6 million worth of savings. But if they just went mad and said, we'll give you £1 billion, there's not £12 billion there. So is it simply a case that we're looking at the very low-hanging fruit because it's something that's not currently being done? Or is there genuine savings to be had as you invest more and more? And what's the drop-off? Has that been studied?
Very good question. So a lot of these estimates, I think, are quite black boxy. It's hard to work out what the estimations are going on, and there are exceptions, but some are, and that's part of the problem, and you put your finger on it. I think all of them are probably only looking at one intervention at the moment, and thinking about a particular size of intervention, and not whether it's, how that would scale up, and you're right to say that it wouldn't necessarily scale up. And I think that's part of the problem of them, is that you can create a sort of league table of these interventions and rate them by ROI, but it's it's of its time and place. You can't necessarily say it'll be true in a year's time, or it'll be true if we've invested the first million, the same will come from the second million.
Sorry, just make these things work? Oh, there. Oh, right, okay. Yeah, and just widening out that point, I mean, throughout my sort of working career in the NHS and academia and so on, the amazing sort of mash-up of terms used for productivity, efficiency, cash savings, cost improvement programs, cash releasing efficiency savings, what the hell is that? There are, economists have some very specific definitions for what efficiency is, what productivity is. They're not the same. Whether they're cash releasing or not, that's not really the history of the NHS. If you look at, I'm talking much broader now, but in terms of how cost-effective things have generated productivity improvements, it's usually just greater volume or greater quality. So I did some work some years back, the switch to generic prescribing, for instance. If we hadn't made the switch over the last 25 years or so in the NHS, our drugs bill would now be double what it actually is for the volume of drugs we prescribe. So the productivity gain has been realized, not in cash savings, but in the ability to do more with the money in volume terms and so on. So I would certainly, I think you said, Sally, about analysts being very clear about these sorts of analyses, return on investment. Does this actually literally release cash? Are we sacking people? Because that's what you have to do, generally, to do that. If not, how do you realize the benefit from this more cost-effective way of doing things?
Adele.
So I really agree with what the other two said. I wish that was our problem. I really wish that we, we're going, is this too much money to put into this really promising? But I think the point remains that we need, when we're thinking about scaling up anything, we need to be very considered about what we're seeking to change, why we think it will work, what the logic model is that sits behind the reasoning for whatever we're seeking to change. And I don't think we do that enough. And the history of kind of public policy intervention here is not great, partly because we don't always take the time to do that, and partly because we have a black box model, as Will said, of evaluation sometimes. But it's not the case that just rolling stuff out will always work, and we should be much more careful.
Thank you. We've got time for one more question. Felix in the front row. Please, Chair.
Felix Greaves, Public Health England. Thank you for great talks. I was struck by your notion of the economic notions of dead weight, and also your discussion about inability to value inequality, perhaps as much as it should do. I worry that often when we have these interventions, when we focus on cost effectiveness and the easiest, the lowest hanging fruit, often hard to reach populations are hard to reach, and it costs more to reach them. So is there a risk that a diligent pursuit of this health economic approach, without that sophistication that you mentioned, which is being developed, leads us up an alley of reinforcing inequalities in a way that is fundamentally perhaps the reason for this protracted, this failure to reduce the inequality gap?
I think that's a brilliant question. Yes, you're absolutely right. I think there's a really well-established evidence base that lots of interventions will have take-up by the wealthiest and most able and those who least need it first, if they're voluntary. When you look across social policy, that's been the case. That doesn't mean you can't do it if you're skillful and careful. One of my previous roles was in young children's services, and I mentioned progressive universalism on my slide. There are models which have worked where you have a universal front door which is incredibly cheap, and then you gradually target those who need it in a non-stigmatizing way. I had one conversation with a children's centre manager who used to talk about the open access clubs that they'd have for all parents. The middle classes flocked to them, but they'd get to know the parents and very skillfully offer, why don't you come and join this group? It would be great for you, to those that really needed it. But it's really hard to bottle that. But I think we need to kind of talk about it more and be more open and value the skill sets at the front line that enable people to do that well.
Very quickly, John, and then we'll probably have to close.
Yeah, very quickly on that. The whole issue about equity weight and sort of analysis has been talked about as long as I've been working for 40 years, really. For economists, I mean, all they'll say is, well, give me the weights, we'll just apply them. Technically, it's not difficult. The problem is, what are the weights? I mean, we do already apply weights within, we weight to get the social value of a QALY and so on, and a lot of work goes into that sort of thing. And so you can imagine we could do it, but we haven't done it so far. And it is a really fundamental issue, which is, what is public health trying to achieve here? Is it maximising QALYs in a sort of rather, crude utilitarian way? No, it's not. But neither is the rest of healthcare either. Otherwise, we'd find those people in society who could benefit most and pour the resources in there, and and forget everybody else. But of course, the system doesn't do that. Just one last thing, I would caution against trying to overload the sort of return on investment, cost effectiveness analysis with trying to solve all these sorts of problems within that. I think there are other, we may just recognise the limitations of that, understand that they don't tell us the full picture of what we want, and then use other methods to make sure that we get what we want from the money we spend.
Okay, thank you very much. I'd love to be able to add to that, but if I just in 10 seconds, I would like to echo the point Sally made about understanding better about public preferences, which is partly an answer to your question as well. What do people actually care about? Because as John says, it's not for economists or others to impose that, it's for us to actually understand what people care about.